Okay, here we go. This is week 11 lecture. Human movement, week 11 lecture. Going to talk about mobility aids, canes, and walkers. Some more on transfers, more advanced transfers getting into this week. Draping, what does that mean what do I mean by draping? And we're going to start tackling some exercises to help you with the wheelchair assignment. Do some cases. It's kind of like a practice kind of thing that we'll start here, finish in the lab to practice what you need to know for your wheelchair assignment. Okay, so part one here, canes, walkers, and this idea of weight bearing. What do I mean by weight bearing? How much weight you can put through your legs as you're ambulating. Here's our lecture questions. In general, mobility aids, again, we're talking walkers, canes and crutches, kinds of things. Physical therapy are the experts on this. Always confer with them. If you're thinking of issues around mobility, if you feel like something is not sized right, I would confer with the PT before you changed it. This is assuming that you're working with a PT. In a lot of settings, you're not working with a PT. Psychiatric, like Acadia, there is no PT there that I know of. Home health, I was by myself a lot of times. PT wasn't readily available. Outpatient pediatric clinics, you're going to be by yourself, not a PT there. But if you're working with a PT, that's ideal. They're experts on gait, ambulation. Definitely want to talk with them. A lot of times your issues around function. You want the person to be able to do as much as possible independently with their device, whereas the PT is just thinking, walking, and keeping them from falling. So you have to kind of, problem solve together. What are examples of what I mean by this? So let's say this person has a walker and they're trying to make a meal, trying to carry things. With the walker, obviously it's hard to carry things because you need two hands on the walker. So there's different kinds of walkers. Walkers with, we'll see one with trays, with seats. You can put walker baskets on them. So you may be advocating, I think this person needs a rollator, which has a seat and a basket usually, versus a traditional walker because they need to sit and wash dishes, sit and make a sandwich, carry items from the kitchen to the living room, always thinking function, function, function. So that's kind of our role in this, along with, you see the sizing is wrong, you see they're struggling, you're worried about falling. Definitely need to speak up and talk with the PT, talk with the team. Okay, so speaking of that, the sizing for the cane and the hemi walker. This is a hemi walker. Hemi as in it's one side, commonly used for people who've had a stroke. So with this person, let's just say his left side is paralyzed or he can't use his left arm, he would have a hemi walker. It's a wider base of support than a cane. It's kind of a walker for one side of your body, I guess. So that's a hemi walker. For a cane, and same with the hemi walker, your sizing, here she is, she's sizing it. Just to keep it simple, from the ground, it should go up to where the crease, with his arm straight at his side, like it is here, should come up to the crease of his wrist. And this is the back side of his wrist, obviously, so you can't see the crease of his wrist. We talked about the wrist creases. There's those wrist creases right where you bend your wrist, where you flex your wrist at the wrist joint. It goes right up to there. And then when he's using it, he'll have a slight bend in his elbow. 20 degrees flexion of his elbow, roughly. His wrist is relatively in neutral, relatively straight, not bent, deviated, or flexed excessively anyway, in any direction. This is kind of what we want. So you size it like this, and then you have this slight degree of elbow flexion. It's the same with a hemi walker as with a cane. And here's the hemi walker sizing. You can see, again, to the wrist crease, and then when he has it, he has that slight bend in his elbow. Nice upright posture. Mobility. Some of these are kind of general rules. They're not hard, fast rules. Things can change a lot in the clinic depending on what's going on with the patient. You could try him pushing up. So his strong side is his right side. I'm sorry, push off with the hemi walker on the stronger side. So the hemi walker is on his strong side. And he's pushing up on his weak side. So he's kind of pushing up with one arm and then standing. In my experience, this is kind of tricky to do. Usually clients are standing up fully and then grabbing the Hemi Walker, or you're standing up and then you're handing the Hemi Walker to them. But maybe this is the next step up. First, they can get up without. They just stand up and grab it. And then as they progress, maybe they can stand up using this to push off. It is a pretty solid base of support, but they have to be pretty able-bodied themselves, not tipping this. So this is something you have to kind of think about. When ambulating, always lead with a weak leg. So in here, as he's ambulating, he's leading with his left leg, which is his weak leg. Here, if somebody's ambulating, so the cane is always on the strong side. So this is his strong side, his right side, and he's leading with his weak leg, which is his left leg. And he's advancing at approximately an arm's length. Here, this is too long, this is too short. The big thing to get out of this is the cane always goes on the strong side. And that seems counterintuitive. There's reasons for that. But just remember, the cane is always on the strong side. And you always lead when you're walking with the weak leg first. The walker sizing, it's similar again. So if her arm is straight at her side, the walker would come up ideally to her wrist crease. And then when she's ambulating with it, she would have a slight bend in her elbow as she is here. This is kind of the more functional walker that I was talking about, more a rollator. It has a nice tray for her meals, for a newspaper. I don't think you can sit on this one, but it allows her to carry things, keeping her hands free to hold onto the walker. She has nice erect posture. She's kind of relaxed. This is some good images about what's good and what's bad. The bad is what you see very commonly. If you see this, you want to confer with the PT, or if you're by yourself, you want to adjust that walker. This man is hunched over his walker. He is not upright like her. We want our clients upright. This is bad news, this hunching. Bad for his back, bad for a lot of things. See how his elbows are fully extended? Don't want that. You want the slight flexion in the elbows. His wrists bearing a lot of weight through there, not very relaxed. Not good at all. This is good. This is poor. And we will do this in the lab. We'll try to size these to each other as you ambulate around campus a little bit. The mobility, when you're walking with the walker, this is kind of a straight standard walker, has no wheels. Usually they're using with wheels. But in some cases they want them without wheels because it provides more stability, slows the patient down. Sometimes they're very impulsive, they're just going too fast. With this kind of walker, and generally speaking with the walker with wheels, don't put it too far out in front of you. It's commonly done. People are like way out with a walker, and you want to step into it. See how he's stepping into the walker? His right leg, and then his left leg, and then he puts the walker forward, and it goes right leg, left leg, that kind of thing. So you're kind of stepping into the walker, not putting it out too far in front of you. These images are a little bit tricky around standing up from a walker. Yes, you can stand up with a walker with one hand on the walker, one hand on the wheelchair. Ideally, I would probably stick it in the middle of the walker versus the side. But this is, again, a little more advanced. For most part, and ideally most settings, I think they're going to tell you, first get up fully. Don't touch the walker. First stand all the way up, push two hands off the chair, and then once you're upright, grab the walker. So ideally, standing up without touching the walker and then putting a hand on the walker. Next level up, depending on where the person is, how safe they demonstrate to you, you could have them get up with one hand on the walker, one hand on the chair. Something you never want them to do, in any case, is two hands on the walker as they're getting up. See how it tips up? This is bad, especially if it's like a wheeled walker. Very unsafe. So we want no hands on the walker or just one hand on the walker as they're standing up. This is okay, better without touching at all. This is bad news. Definitely do not want to be doing this. Crutch sizing. The hand grip height, this right here, goes right around your hip, right at trochanter level. It's like it is right there. And a good little simple check to see if the pad's in the right spot. A two-finger check. Got like 3 fingers in it, but at least 2 fingers right there is good between the top of the pad and your armpit. Don't want it jammed up into the armpit. It's very bad news. As you probably know at this point, your brachial plexus goes right through there. And you can cause nerve damage and discomfort if you're pushing up into your axilla, your armpit all day long on these crutches. It can be very, very difficult to use crutches. And I'm sure some of you have used crutches. Very intense, very challenging to walk with crutches, and you don't want to be wheeling on your armpits all day as you're doing it. Sit to stand, again, this is kind of higher level. I would think originally, especially for older folks, most of the clients we're dealing with, they're going to be standing up first with 2 hands, and then you're going to be handing them the crutches. But as they progress, 1 hand on the wheelchair, 1 hand on the crutches. The gait progression with the crutches, again, weak leg first, strong leg, and then the crutches. And you're bearing weight through the hand grips, not the armpit. That really bears repeating. Bearing weight through the hand grips, these things, not the armpit. Stairs, going up with a good leg, down with a bad leg. So she says her injured leg, she's leading with her good leg. When she comes down the stairs, she'll reverse it. She'll be leading with her injured leg. This is a simple expression, a little bit kind of crude, but it works with clients. I always say this and they don't forget. Up to heaven, down to hell. So up to heaven, good leg leads first. Down to hell, bad leg leads first. And again, you're bearing weight through the grips, not your armpit. Touch toe weight bearing. What is touch toe weight bearing? You're going to get all kinds of degrees of weight bearing with your patients in the hospital. Of a total hip or total knee replacement or some kind of leg surgery, and it's starting to heal, and the surgeon will say, ambulate with 50% weight bearing. Ambulate with 10 pounds weight bearing. You know, these different degrees of weight bearing. One of those you're going to get, for an example, is touch toe weight bearing. The foot or toe may touch the floor but not support any weight. We'll practice this one. Don't feel like you have to know all these right off. All these you will learn on the job in the setting that you're going to be at. But with the touch toe, just give an example. You're not really placing any weight on the affected foot. It's just kind of a quick touching down and coming up. Imagine having an egg underfoot that you can't break. That may help you and your client. Touch toe weight bearing. Just be aware that this weight bearing status thing is a big deal when you're looking through the chart, deciding how to ambulate your patient and those safety precautions. Okay.